We're going to discuss some questions relevant to the ESE exam. When we do those on live event, you could probably join me on this menti.com using this code to discuss the questions. So this is just a trial to see if that's something we could do live in the future. First question is: a 68-year-old man with end-stage kidney disease twice weekly on hemodialysis for the last 10 years, presented with hyperkalemia, pre-dialysis hyperkalemia, and reduced dialysis adequacy in the past month. He reports prolonged bleeding as well from the fistula, which is radiocephalic. He's on the following medication, but there's no recent change in those, and his pre-dialysis blood result as follows: potassium 6.5, clearly is high, bicarbonate 18, and urea 28, creatinine 820 micromole per liter. His single pole KT over V fell from 1.6 to 1.1, so clearly he's got inadequate dialysis over the last 6 weeks. An examination, thrill present, so fistula still functioning, prolonged post-dialysis bleeding, and some swelling in the hand and forearm. So here we go, the 5 options. So what is the next best step in the management? Reduce dialysis potassium to 1 millimole per liter, check whole blood potassium to exclude pseudo-hyperkalemia, obtain fistulogram with a view to do angioplasty, stop lisinopril, increase the dialysis session by 60 minutes. Right, here we go, some time to think about the answers and make your mind. As I said earlier, when it is live, you could see the changes in the percentage of people who's answering, and then we can see the result together. Right, so the answer is C, obtain fistulogram in view of doing angioplasty if there's obstruction. Clearly, there's a prolonged bleeding and adequacy has gone down due to recirculation. There's arm swelling as well. All these suggesting that the dialysis is not adequate, especially in cases with hyperkalemia. In patient who has normal pre-dialysis potassium all the way along, all of a sudden on monthly blood, you find hyperkalemia, then you need to exclude recirculation due to access problem. For example, if there is stenosis or thrombus distally to the fistula, then that's need really looking at by fistulogram and plus minus fistuloplasty. Usually they do balloon angioplasty to open the stenosed vessels, for instance. Why not others? So 1 millimole path, to do path 1 millimole increase potassium removal by marginally and carry arrhythmia risk from transient hyperkalemia. And it does not fix, of course, the underlying problem. Option B, whole blood potassium check, useful when it's pseudo-hyperkalemia suspected, of course, for example, in thrombocytosis, leukocytosis, or traumatic phlebotomy. Count are normal and the clinical picture fits access dysfunction, so not the best next step in this case. Again, stop lisinopril. Patient did not have problem with this potassium before, so it's not going to fix the underlying cause. And it does cause significant hyperkalemia in an uric patient, but won't correct the poor dialysis clearance. You could potentially, there's nothing wrong to hold it off until the potassium sorted and the underlying problem get fixed, but not going to be, fixing the underlying problem. And the last option, longer dialysis session, again, may improve clearance temporarily, but again, if there is a significant circulation, it's not going to address that. And definitely evaluation of the underlying problem is required to repair the access. I hope this is useful, and if you do find it useful, please let me know so we can do live session to make some revision together. I wish you all the best, and goodbye.